Okay, let's get started. Hi, everyone, and welcome to the McMaster Health Education Research, Innovation and Theory, or the Merit Center Education Rounds. I am Dr. Elif Bilgic, and I'm an education scientist and assistant professor in the Department of Pediatrics and the Merit Center. Now, the Merit Center is an education services center in the Faculty of Health Sciences dedicated to advance health professions education scholarship via a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. Although today's education round is virtual, many of us in this event are connected by the land on which we work. So I want to take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Bell. That wampum uses the symbolism of a tish to represent the territory and one spoon to represent that the people are to share the resources of the land and only take what they need. Before leaving the stage to our esteemed guest today, I will provide a very brief introduction. The title of today's education round is Rethinking Social Accountability in Health Professions Education, Concepts, Challenges, and Implications. And we have Dr. Cassandra Barber as our speaker. Dr. Barber is a demographer, researcher, and educator specializing in health professions education. She is an assistant professor and education scientist in the Department of Surgery at McMaster and an adjunct scientist with the Merit Center. Dr. Barber brings expertise in social accountability, particularly in linking education structures to population health outcomes. Her scholarship explores how training systems, policies, and workforce patterns shape equity and population-level outcomes. With her expertise in mind, the rounds today will focus on examining the evolving concept of social accountability in medical education and its implications for postgraduate training. Drawing on international frameworks, foundational literature, and her own scholarship, she explores why social accountability remains difficult to define, measure, and implement meaningfully. During the rounds, feel free to use the chat for comments and questions, as I will ask those during the Q&A period. Also, during the Q&A, you can ask questions by using the hand-raising function on Zoom. So without further ado, Dr. Barber, please go ahead.
Thank you for the kind introduction. First, I want to thank everyone for joining virtually this evening. I really appreciate you taking your time to be here. Tonight, I want to take a closer look at a term we use frequently in health professions, social accountability, and reflect on what we actually mean when we use it. Rather than focusing on outcomes, models, or best practices, the session is about concept, meaning, and consequence. I will be asking how social accountability has been defined, how the field has attempted to operationalize it, and why the transition from idea to evidence is often more complicated than it appears. My hope is to not provide definitive answers, but to initiate collective reflection on what it means when we say social accountability. I will also note that the challenges I will discuss tonight are not unique to health professions education, but reflect broader challenges within the accountability literature that cut across discipline and emerge when working with complex structures that are difficult to define and even more challenging to measure. During this session, I will move through a few linked ideas. I will begin by looking at why social accountability is conceptually challenging before tracing how the literature has tried to define and operationalize it over time. I will then focus on two dynamics that become especially important once accountability is tied to measurement: the performance paradox and Goodhart's law, and why they matter for education and evaluation. From there, I will shift towards a systems-based perspective and end with some reflections on why this way of thinking offers health professions education a way forward. With that overview in mind, I will start by stepping back and looking at accountability more broadly, before layering in the social dimension. One of the reasons social accountability becomes so difficult to understand is that the underlying concept of accountability is far from settled. We often treat accountability as self-evident. Historically and philosophically, it has been defined in multiple, often competing ways. Those differences matter because how we understand accountability shapes what we choose to measure, how we interpret evidence, and what kinds of claims we think we can reasonably make. This slide captures the tension many of us encountered when working with large, complex concepts. Accountability is often described as a conceptual umbrella, with chameleon-like qualities. It shifts depending on context, audience, and purpose. It is used interchangeably with responsibility, answerability, effectiveness, and even transparency. Despite decades of scholarship, there is still no shared agreement on what it means to fulfill an accountable obligation. And importantly, the concept has continued to broaden rather than narrow, which creates both flexibility and confusion. So before we can evaluate social accountability, we have to be honest about what accountability is doing as a concept and why it is challenging to pin down. At its simplest, accountability refers to answerability, an obligation to give an account and be held responsible for one's actions. But conceptually, it's relational. There's an accountor, the actor or institution, and an accountee, the person or body to whom explanations are owed. This principal-agent relationship matters because it reminds us that accountability always operates through power. Who sets expectations, who judges, and who has the authority to decide what counts as a satisfactory account. Once accountability is understood as a relational concept shaped by power, it becomes easier to see how measuring shifts within educational settings. In education, accountability functions as a system used to evaluate institutional effectiveness. It tends to involve a set of institutional goals, indicators, decisions, rules, incentives, and consequences, all of which is grounded using feedback loops intended to inform improvement and decision-making. And there are many typologies, including legal, bureaucratic, professional, political, market, and moral. But what unites them is a shared set of questions. Who is held to account? For what? To whom? And through what means? So if educational accountability is a system, then conceptually, ambiguity is not just theoretical, it becomes a practical design challenge. Despite how common the term is, accountability lacks universality. Even translations often collapse into responsibility, which changes its meaning. And it has a vague, iconic qualities. Terms like accountability can sound reassuring in policy documents, and even they remain operationally unclear. I want to emphasize that conceptual ambiguity is not a flaw, but it shapes what is known and evaluated. That is the epistemological core to the rest of this talk. This is where I want to make something explicit. Accountability is not only a governance or a policy concept, it's also a knowledge problem. Definition shapes what we see, measure, and justify. They influence what counts as evidence, whose priorities are foregrounded, and how success is interpreted. And conceptual ambiguity creates both flexibility and risk, especially when accountability is tied to reform, program evaluation, or equity-focused work. With that framing in place, we can now look at what happens when accountability becomes social accountability in health professions education. The WHO's definition of social accountability in medical education emphasizes an obligation to direct education, research, and service towards priority health concerns of the community and or the regions they are expected to serve. Later, a global consensus on social accountability pushed this further by emphasizing social accountability as a measurable activity, an action to respond to current and future needs. This dual framing, value plus measurability, is important. It is one of the reasons why social accountability becomes both morally compelling and methodologically difficult. These value commitments, relevance, quality, cost effectiveness, and equity are often treated as the ethical backbone of social accountability. The challenge is translation. How do these values become educational decisions and evaluative claims? Values are easy to state. They are harder to operationalize consistently, especially when trade-offs emerge. This distinction, known as the social obligation scale, is helpful because it separates awareness, action, and evidence. Responsibility is awareness of duties. Responsiveness is of course of action. And accountability is measurable activity, evidence that actions proactively meet societal needs. Most institutions or programs are strong on responsibility and responsiveness. Accountability is where the evidentiary challenge emerge. Once we accept that accountability requires evidence, the next question is, how has the field tried to operationalize social accountability? Social accountability is often justified through a broader social contract between health professions, education, and society. Through legislation, regulation, and accreditation, programs are entrusted to educate physicians prepared to meet societal needs. What matters here is that this contract is often implicit. It shapes priorities and expectations, even when it is not explicitly evaluated. Social accountability may be one of the ways the literature has tried to make the contract more explicit. This is the pivot into frameworks and tools. The literature has tried to translate a normative ideal into something actionable, something that can be evaluated, compared, improved, and reported. Flexner is not a social accountability framework in the way we use the term broadly today, but it has shaped medicine aligned with societal expectation of the time, especially around standards, training, and public service. The point is to not treat Flexner as the origin story, but to show that accountability has been long present in medical education. What changes over time is whose needs are foregrounded and how those needs are interpreted. So you do not need to read this in detail. What matters is the pattern. Sorry. We see international, national, and institutional tools multiplying over time, often with increasing specificity. This reflects a desire for clarity and measurability, but it also raises the question, does more structure necessarily translate into meaningful impact? Despite expanding awareness, the translation of social accountability into practice remains uncertain. Institutions may demonstrate commitment, but the impact of educational outcomes on communities often remains unknown or unevaluated. This is simply an observation about what becomes visible when social accountability is operationalized through tools. And this is where measurement becomes central, because the push for evidence often brings unintended consequences. This section is about a familiar tension. When we turn complex goals into indicators, we gain legibility, but we also risk distortion, and following ideas help us explain why. Most of us are familiar with Goodhart's law. It's straightforward. When a measure becomes a target, it ceases to be a good measure. The problem is not measurement itself, It is how people and systems adapt once success is narrowly defined. Once indicators become targets, effort shifts towards meeting the metric rather than achieving the underlying goal. And this is where good intentions start to unravel. The performance paradox describes weak correlation between indicators and actual performance, and it outlines predictable dynamics: positive learning, perversive learning, selection, and suppression. The key point is that these are not individual moral failures. Rather, they are structural responses to how social accountability is designed. When this plays out in social accountability work, we see drift. From meaning to compliance, from engagement to documentation, from long-term outcomes to short-term legibility. Equity and population impact are particularly vulnerable because they are harder to measure, slower to emerge, and more sensitive to context. This is where knowing, doing, and appearing to do starts to separate. Social accountability can become treated as a programmatic checklist rather than a primary focus. Standardized indicators can ignore contextual differences, sometimes disadvantaging underserved population and unintentionally reproducing inequities. That is the paradox. A concept designed to advance equity can, if operationalized poorly, help stabilize inequities. So the question becomes, how do we evaluate social accountability without falling into these traps? A system lens shifts us away from a single metric and isolated initiatives towards understanding how admissions, training locations, assessment structures, and policies interact over time. It also shifts in what counts as evidence. Not only whether something was implemented, but what change, what patterns emerge, what unintended consequences appear, and what impacts become visible or remain invisible. Traditionally, evaluation focuses on input and processes. Those are necessary, but not sufficient for social accountability. A systems-based approach moves us towards outcomes and impacts, recognizing that meaningful change often unfolds slowly, across boundaries, and with complex causal pathways. But it does not mean we should abandon indicators. It means situating them within the broader logic. Viewed this way, social accountability is not a discrete achievement. It is an ongoing alignment problem. It involves feedback, adaptation, and course correction over time. A system approach creates space for learning, uncertainty, and complexity rather than forcing everything into a simple compliance narrative. So I want to close by returning to where we started. Social accountability is widely endorsed and morally compelling, but it remains conceptually fluid and vulnerable to distortion when translated into indicators. Rather than treating the problem to solve, I would suggest it is a condition we need to work within. For me, the key shifts from moving from asking, are we socially accountable, to how do our education systems impact societal health outcomes over time and for whom? So I want to pause here with questions rather than conclusions. This talk is not intended to resolve the conceptual or operational challenges we have discussed today, but to invite deeper reflection on what we mean when we say social accountabilities. And I'm hoping to kind of take the moment to think about how these questions really impact the work that you're doing. So what assumptions are embedded in how we currently operationalize social accountability? What outcomes matter most, but are least visible in our systems? And where might accountability metrics unintentionally reinforce inequities? And what would it mean to study social accountability as a system rather than a set of initiatives? And I'm happy to answer any questions.
Great. Thank you so much, Cassandra. Feel free to stop sharing your screen. Okay. Thank you so much. I know it's 6:02. We have come to the end of our education rounds for January. Thank you so much again, Dr. Barber, for an awesome presentation and an awesome discussion period. And thank you to all of you for attending and engaging. I hope to see you all in our next rounds, which will be in February. So thank you, everyone, and have a great evening.
Thank you.
Bye-bye.